Welcome, and you're back with us at the Health Hour. Today our topic is palliative care and Liverpool care pathway. We discussed before the break a lot about palliative care, what it is and what's involved. Now we're going to touch upon the Liverpool care pathway. And so this is a pathway that was developed by the Liverpool Royal Hospital and also by Marie Curie Hospice in Liverpool in the early 1990s. It was a pathway that we put people on who we have decided that they've coming towards the end of their lives with maut ke kareeb aa rahe hain, and it's to give them supportive care. So we have a special guest with us today. He's a consultant palliative physician at Manchester Royal Infirmary, Dr. Ahmed. Dr. Ahmed, from what I understood from our discussion before the break is that the LCP, which is the Liverpool care pathway, is a pathway that provides high quality care to patients who are coming towards the end of their life, last few hours, last few days of their life. Is that correct?
That's true. The Liverpool care pathway was originally started in Liverpool by the Marie Curie Hospice in Liverpool and the Liverpool Broadgreen hospitals. And the objective उसका मकसद ये था कि to help people have a good death. So what the pathway was doing was to make sure that there's enough comfort measures for those people who are in the last days of life or who are in the last hours of life. And that's been around for now, starting probably late 90s, early 2000s, and it's still there at the moment. But as you may have heard, there's been a lot of debate around the pathway.
Yes, some people have mentioned in the press that it's a one-way street to death. कहते हैं कि अगर doctors ये LCP पे लगाते हैं, they're trying to kill you, and they feel that they're trying to quicken the death process, because in today's day and age we have a lot of elderly people, limited resources, high population numbers. How do you feel about that? Do you feel that it quickens the dying process?
Definitely not. I mean, as doctors, we're not allowed to shorten life anyway, and ethically we are against it. लेकिन जैसे आपने सही फरमाया, there's been a lot of public debate around the Liverpool care pathway. उसके शायद दो वजूहात हैं. One is probably about the public perception, public ये जो understanding है कि शायद Liverpool care pathway can shorten people's life.
Okay, I'm going to have to interrupt you.
That's
there.
Right.
We have a caller. Assalamu alaikum.
Assalamu alaikum.
Wa alaikum assalam. Who's calling?
Hello.
Assalamu alaikum.
Assalamu alaikum.
Thank you for calling our Health Hour program. Please ask your question.
This is Zaria, your mom's.
लगता है कि ये बच्चा बोल रहा है. कोई adult present है? Okay, that call's been dropped, unfortunately. So you were mentioning that the LCP is more supportive care.
It is.
I'm sorry. Again, we have another caller. Assalamu alaikum.
Hello.
Assalamu alaikum.
Hello, assalamu alaikum.
Wa alaikum assalam.
आपकी आवाज़ अच्छी तरह नहीं आ रही है. Hello, assalamu alaikum.
Wa alaikum assalam. बहुत बहुत शुक्रिया आपने कॉल किया. आप क्वेश्चन करें प्लीज. आपका क्वेश्चन क्या है? हेलो.
मुझे एक सवाल करना था.
जी.
हेलो.
आप करें सवाल.
हाँ, मैं ये कह रही थी कि वो जो आपने जो मेकअप किया ना, ज़्यादा मेकअप बहुत ज़्यादा.
ये भी कॉल कट ऑफ हो गया. Okay. So we were talking about LCP and which patients are allowed on the LCP, why it was brought about. We're also talking about the controversy around the LCP, that people believe that it's to quicken the dying process. How do you feel about that?
Well, yeah, as I said, it definitely, the objective is मकसद ये नहीं कि that it quickens the dying process. लेकिन public perception शायद ये है कि it quickens it. Because partly वजह ये हो सकता है कि because the Liverpool care pathway is usually started when people are in the last days of life, जब उनके सिर्फ कुछ दिन रह जाते हैं. So if someone is dying, it's not because of the Liverpool care pathway, it's because they are in the last days of life. The Liverpool care pathway is used to help them have a good death. एक अच्छी
जब आप कहते हैं कि good death, can you expand on that?
Of course.
क्या है आपका कि अच्छी death हो?
Yeah, I think हमेशा हम डॉक्टर्स को ये ट्रेनिंग दिया है कि that we should find cure for everything. And which is good. We always try to save the patient. But हकीकत ये भी है कि that at some point everyone dies despite whatever treatment they receive. और experiences ये है कि sometimes patients who are dying in lot of pain, or they're dying because they're getting very confused and becoming very unwell, and they're not having a good death. Whereas what we would like to do is to make sure that they are pain-free and that they're comfortable, and that they're dying, and when they're dying in peace with their family around them. So that is what we mean by good death.
Okay. तो अगर पेशेंट चाहता है कि वो घर में मौत आए, फिर कोई फैसिलिटीज़ हैं कि that you allowed them to die at home?
बिल्कुल. आजकल जो गवर्नमेंट का ये कोशिश भी ये है from the Department of Health कि अगर कोई patient, if they are in the last days of life and if they want to die at home, then we should do everything possible जितना हमसे हो सके to help them do that. और वो इस तरीके से हम करते हैं कि as I mentioned earlier about you can have palliative care Macmillan nurses who will come to the patient's home to help with the pain and those symptoms, so the patient can have a good death in the around the near ones.
तो डॉक्टर अहमद, अक्सर मैंने देखा हॉस्पिटल्स में कि डॉक्टर्स जवाब देते हैं कि अब हम अभी ये पेशेंट का कुछ नहीं कर सकते, पर फिर भी रिलेटिव्स आते हैं हॉस्पिटल में, कहते हैं कुछ करें इनका, कोई इलाज इसका लाएं. आप इस सिचुएशन में आप क्या करते हैं? क्या how do you resolve this?
First of all, we talk to the relatives. We find out why they're worried about things. We also find out, हम ये भी पता लगाते हैं कि उनको किस हद तक पता है अपने पेशेंट के, अपने रिलेटिव के बारे में. हो सकता है कि उनको पूरा पता नहीं हो कि डॉक्टर्स ने काफ़ी कोशिश किया हुआ है. So we try to explain to them कि मतलब the doctors have tried everything possible. क्योंकि उसके बावजूद हम without trying everything we will not be putting them on the pathway, we will not get end of life plan in action.
I see. अक्सर मैंने देखा कि relatives loved one को लाते हैं, कहते हैं ये खा रहा नहीं, ये पी रहा नहीं, क्यों नहीं खा रहा, ड्रिप लगाएं. आप कैसे समझाते हैं इनको कि ये इसलिए नहीं खा रहा because he's मौत के करीब आ गया?
Exactly. I mean, again, हम उनको explain करते हैं कि वो इसलिए नहीं खा रहा है because वो चाहते नहीं हैं. उनके बॉडी इतना वीक हो चुका है कि वो प्रोसेस नहीं कर सकते. और अगर हम फोर्स फीड करेंगे, कभी कभार ट्यूब लगा के हम फोर्स करते हैं, तो वो उल्टा नुकसानदेह हो सकता है, क्योंकि वो फिर उल्टियाँ शुरू हो जाती है, क्योंकि वो बॉडी एब्जॉर्ब नहीं करता खाना, उल्टा वो उल्टियाँ शुरू होती है, वो ज़्यादा मसला होता है. जहाँ तक पीने की बात आ जाए, तो अगर बहुत ज़्यादा बिल्कुल पी नहीं रहे तो हम ड्रिप तो ज़रूर शुरू करते हैं, लेकिन उस पर भी एक बैलेंस है, क्योंकि हम ज़्यादा वो फ्लूइड देंगे ड्रिप के ज़रिए तो वो फिर उनके दिल पे ज़्यादा बोझ बढ़ जाता है, फिर वो ज़्यादा उस पर लंग्स में पानी जम जाता है.
Okay, Dr. Ahmed, sorry, I need to interrupt you there. We've got another caller on the line.
Hello, assalamu alaikum.
Wa alaikum assalam.
My name is Amir, and I was just watching the show. It was quite informative, and I just want to appreciate you. You're hosting quite well. I really like your program.
Okay, thank you very much. Thank you. Do you have a question? He's gone. Okay, उन्होंने बस यही कहना था कि वो शो को appreciate कर रहा है. Okay, thank you very much for calling. Dr. Ahmed, one aspect I wanted to ask you about is palliative medicine is a very great, vast specialty. You know, you've got patients with complex needs, you need to visit the same people often all the time, and there's insufficient time, limited resources. There's very challenging symptoms that you deal with, and a lot of communication problems as well. I wanted to ask, what's the difference between palliative care and end-of-life care?
That's a very good question, because I think that's what people sometimes confuse between palliative and end-of-life care. End-of-life care जो है palliative care का एक हिस्सा है. It's a part of palliative care. Palliative care mainly means symptom management and holistic care of patients with life-limiting conditions. जैसे मैंने बताया, कोई कैंसर के मरीज़ हो गया हो या कोई advanced heart condition मरीज़ हो गया हो, so they need not be dying at that point of time. तो एक कैंसर मरीज़ होगी, he may still be having treatment, लेकिन फिर भी उनको दर्द महसूस हो रहा होता है.
जी.
So that is where I as a palliative care physician comes in to help their pain. The cancer specialist will deal with the cancer treatment.
जी.
So we both do our own things.
Yes.
लेकिन वही मरीज़ हो सकता है कुछ महीने बाद या कुछ सालों बाद उनका कैंसर बढ़ जाता है और वो they may be approaching their end of life. That's when then I give them end of life care. So palliative care is not just end of life care, it starts even long before that. If
Okay. We have another caller on the line. Hello, Assalamu alaikum.
Hello.
Assalamu alaikum.
Assalamu alaikum.
Well,
Thank you for calling. Do you have a question? Hello? लगता है आवाज़ नहीं आ रही. Okay, we will continue our discussion. We're talking about symptoms. मेरे एक्सपीरियंस में मैंने also भी देखा कि relatives रिश्तेदारों को हॉस्पिटल आते हैं कहते हैं कि ये agitated हो रहा है, restless हो रहा है, confused हो रहा है. ये क्यों होता है at the end of life?
मुख्तलिफ वजूहात है. One could be because when we know that from research that when people are approaching end of life there can be a lot of what's in medicine called biochemical abnormalities, यानी उनके ब्लड के अंदर मुख्तलिफ चीज़ें बढ़ रहा होता है. मिसाल के तौर पर कैंसर पेशेंट को कैल्शियम बढ़ जाता है उनका, या उनके ऑक्सीजन की कमी होती है. तो ये चीज़ें हैं जिसके वजह से कन्फ्यूजन पैदा हो सकता है. तो अगर ये वजह है तो उनके लिए बाकायदा अगर ऑक्सीजन की कमी हो तो हम ऑक्सीजन दे सकते हैं, कैल्शियम बढ़ गया तो कैल्शियम की ट्रीटमेंट दे सकते हैं. लेकिन हमें ये भी पता है कि इन सब के बावजूद कन्फ्यूजन फिर भी हो सकता है. इट कैन कैरी ऑन स्पेशली इफ दे आर द लास्ट स्टेज ऑफ लाइफ. फिर हमें कुछ ऐसी दवाएं देना पड़ेगा हमें ताकि वो थोड़ा रिलैक्स्ड हो सके और काम हो जाए, और उसके लिए दवाइयाँ हैं हमारे पास.
ओके. तो आप बता सकते हैं कि आप कैसे डिफरेंशिएट करते हैं कि ये डिमेंशिया है या कन्फ्यूजन है?
Well, first of all, we look at the patient's history. So हो सकता है, we will know from before that the patient has got a history of dementia. Then if they're confused, we would do some blood tests to see whether there's any other cause for confusion. जैसे मैंने बताया, any calcium or something. We would also look at their oxygen levels. We would look if they got any infection. So we would look at to see what is the cause of confusion and treat it accordingly.
Okay, I see. Okay. I wanted to ask a little bit about, you mentioned before in the hospital you have the hospital chaplain.
Yes.
You have other religious people there to help for different people alternative beliefs. Can you tell me a little bit more about what other supportive strategies there are for not just the patient who's passing away but for the relatives?
Yeah. Well, as we discussed earlier, as part of my team, we've got a psychologist who can provide psychological and emotional support, not just for the patients but for the family as well.
And does this continue until after the patient passes away? How long does it go on for?
It does. I mean, there's something called the bereavement services. So, जैसे मैंने आपको बताया, you get people who can support the family while they are near dear ones are dying, but also उनके मौत के बाद अगर उनको support चाहिए तो we've got the bereavement services who can support them. अब किस हद तक, for how long you have to do that will depend on each individual situations.
Okay, so ये individual पे depend करता है कि क्या होता है.
बिल्कुल.
Okay, and हम देखते हैं कि hospital में जब person like death हो जाती है, some of them have a postmortem, लेकिन दूसरों की postmortem नहीं होती. ये क्यों है ये difference?
Postmortem हमेशा तभी करते हैं जब of course in a medical scenario, not in a criminal scenario, they do postmortem when you cannot find the cause of the death. एक ये वजूहात है. और दूसरी वजह है जब when there are what's called as communicable diseases, जैसे infections जो बाकी society के लिए जैसे TB हो गया या ऐसे कोई diseases, या what's called as occupational diseases जैसे mesothelioma, जिनके ज़रिए अगर आपको confirm हो गया कि आपको mesothelioma है मिसाल के तौर पर, then you can get compensation, आपके family को compensation. तो ऐसे दौरान postmortem होता है. But you can always, with regards to postmortem, if there are especially Islami तौर पे, if people family are against postmortem, you can always discuss with the hospital and see whether they can find a way around it as well. There may be certain scenarios where you can't, but sometimes you can.
Okay, तो ये scenario पे depend करता है.
बिल्कुल.
Okay, And what do you feel अगर the patient says कि मैंने LCP पे नहीं जाना, मैंने बस active treatment करना है, जो कुछ भी हो मुझको सब treatment चाहिए, you know, what do you do in that situation?
First and foremost, we will not do anything against the patient's wishes. तो अगर patient ने बता दे कि मुझे LCP भी document में नहीं जाना, that's perfectly fine, because end of life care should go can go with or without the LCP. LCP सिर्फ एक extra help है ताकि हम doctors और nurses को ये बता सके. It's like a chart, a guide sheet to help provide good care. But if अगर किसी को कोई एतराज़ हो LCP से, then we can stop that. There's no problem. The other aspect of LCP is it's not a one-way street. You know, if अगर कोई LCP में, if someone started in the LCP, और अगर वो they can happen rarely that they improve, उनका condition improve हो सकता है, तो फिर you can stop the LCP. क्योंकि LCP में खुद ये है कि अगर आप कोई patient LCP में हो, then you are the doctor should see the monitor the patient daily. और अगर उन्होंने देख लिया कि patient की condition improve हो रहा है, then they may even consider stopping the LCP. So it is definitely not a one-way thing.
Okay, Dr. Ahmed, this is a very good point because we believe that about roughly 3% of people who are on the LCP वो वापस उतर जाते हैं from the LCP.
बिल्कुल.
तो ये क्यों होता है?
I mean, I think it comes back to the fact that we can predict or we can estimate most cases, but in medicine we can never get everything right.
Yes, nothing for definite.
Nothing's for definite,
yes.
and that's part of the reason why it's important to review to monitor patients around the LCP. So doctors लोग aware है, उनको पता है ये हो सकता है, इसीलिए review करते हैं. So in some ways it is good that LCP is flexible. Flexible है, बिल्कुल.
Okay, that's fine. Another thing in hospitals they have something called DNAR, which is do not resuscitate. And sometimes doctors ये फैसला करते हैं कि हमने इसको resuscitate नहीं करना. तो इसका मतलब है कि we do CPR, सीने पे हाथ लगाते हैं, and we try and get the heartbeat back and start breathing again. तो in which situations कि आप ये decision लेते हैं कि हमने DNAR करना है, तो कौन ये decision लेता है?
बिल्कुल. DNAR या do not do CPR decision is usually taken by the patient's own consultant. या कभी कभार they discuss with us and we make a joint decision लेते हैं. DNAR decision कभी भी हम lightly नहीं लेते. DNAR decision हमेशा we look at the patient और हम ये again जैसे मैंने आपको पहले बताया कि देखते हैं कि patient को किस हद तक treatment हो चुका है और किस हद तक उनका improvement हुआ है. और दूसरी बात है कि DNAR is only it's only a decision for CPR, जो जैसे आपका दिल धड़कना बंद हो जाए तो that they would say they will not be able to do CPR. उसका वजह ये है कि उनको पता है कि अगर उन पे CPR करेंगे तो patient जिंदा नहीं, they can't bring back the patient. And instead ये होता है कि patient will have a very traumatic death. क्योंकि CPR काफ़ी ट्रॉमेटिक है, क्योंकि प्रेस करना, आप चेस्ट पे प्रेस करते हो, आपके हड्डियाँ टूट सकते हैं और उसके बावजूद आप अपने पेशेंट को बचा नहीं सकते. तो इसीलिए डॉक्टर लोग चाहते हैं कि अगर पेशेंट को उनके दिल रुक जाए, then they don't think for that specific patient it's not appropriate because they know what's happened to the patient before. तो हमेशा DNAR एक individual patient पे decision लेते हैं. और ये दूसरी बात ये है कि DNAR does not mean the patient does not get other treatments. तो patient can still get antibiotics, drip, बाकी सब कुछ हो सकता है. सिर्फ ये कि अगर खुदा न खास्ता उनका दिल बंद हो जाए, then the doctors feel that for that specific patient वो नहीं कर सकते because they'll not be able to help the patient, but they may actually cause more harm to the patient.
Okay, तो ये फैसला करते हैं on a case by case basis, individual decision होता है. Okay, I see. तो ये decision like patient ले सकता है, कह सकता है कि मैंने do not resuscitate me please.
बिल्कुल. I mean कभी कभार ये भी हो सकता है कि हम डॉक्टर लोग सोचते हैं कि if at all this specific patient's heart stops, we might be able to save him. लेकिन पेशेंट ने फैसला कर चुका होता है कि नहीं, मुझे नहीं चाहिए, तो हम पेशेंट के डिसीजन रिस्पेक्ट करते हैं.
लेकिन रिश्तेदार they come to the hospital, कहते हैं नहीं आप ये कुछ करें इनके लिए, आप क्यों नहीं ये resuscitate कर रहे हैं, आप उस सिचुएशन को कैसे हैंडल करते हैं, कैसे आप समझाते हैं फैमिली को कि ये पेशेंट ने ऑलरेडी डिसाइड कर लिया कि मैंने नहीं रिससिटेट होना?
आई मीन अगेन वो जैसे मैंने आपको पहले बताया, हमारे एज मेडिकल टीम हमारी सबसे पहला हमारा फ़र्ज़ पेशेंट की तरफ है, एंड पेशेंट हैज़ गॉट द फाइनल से, स्पेशली व्हेन इट कम्स टू स्टॉपिंग ट्रीटमेंट्स. तो अगर पेशेंट ने फैसला कर चुका है और पेशेंट वी मेक श्योर द पेशेंट गॉट द मेंटल कैपेसिटी टू मेक द डिसीजन, और उन्होंने ये फैसला कि उनको DNA और they don't want to be resuscitated, then we respect that. और अगर उनके रिलेटिव्स को एतराज़ है तो हम फर्स्ट ऑफ ऑल एक्सप्लेन टू द relatives as to why we are doing this, because it's the patient who wants it. We can always if they're not happy with that, फिर हम एक और मीटिंग रख सकते हैं पेशेंट के साथ if it's appropriate, कि क्यों हो सकता है कि पेशेंट और अपने रिलेटिव्स के आपस में उनका डिस्कशन नहीं हुआ हो. So sometimes when they have a chat together, then that will add a lot of misunderstandings.
Okay, and that makes things a little bit clearer.
That makes things a little bit,
okay. तो आप ये कैसे एनालाइज करते हैं कि जब पेशेंट कहता है कि मैंने रिससिटेट नहीं होना, कि वो दिमागी तौर पे सही है और सही बात कर रहा है, उनकी अपनी डिसीजन है, कोई और नहीं बता रहा कि ये आप DNAR हो जाओ?
बिल्कुल. अगर जैसे मैंने आपको बताया, अगर हमें कोई ऐसा कोई पेशेंट है हमारे पास कि जो हम सोचते हैं कि that we should be able to resuscitate, and if the patient still does not want it, then we do what's called a mental capacity assessment. We can do that. We can keep on, we can ask the patient once, let us say, and we will always, हम ये भी patient कहते हैं अगर उन्होंने अपना decision change करेंगे मुस्तकबिल में, in the future, then we can always reverse that decision as well. So we can again repeat that question again the next day to make sure that the patient does not change the decision.
I see.
So the patient's always got the, again it's not a one-way street. If the patient thinks that no, I want to be resuscitated, and if it's appropriate, उस वक्त appropriate है, तो we can tear off the CPR form.
Okay, I see. तो वो patient लिख देता है कि मैंने नहीं resuscitate होना है, क्या procedure है?
हाँ, patient बाकायदा लिखने की ज़रूरत नहीं है, but if the patient says that this is what he or she wants, then as doctors we have to document it in the medical notes. कि हमें time और discussion बाकायदा document करना कि ये patient ने फैसला किया कि उनको CPR नहीं चाहिए, तो हम ये करते हैं.
Okay, I see. I want to touch back on the Liverpool Care Pathway. So it's been around for a few years now. It's working well, but I think Department of Health announced in July this year that they're going to introduce a few changes, or perhaps bring in something new to replace the LCP. Can you please enlighten us on this?
I think जैसे मैंने बताया, there's been a lot of publicity around the Liverpool Care Pathway. Shayad it's probably based on some of the कुछ गलत फहमियाँ within the public, and also probably within the doctors in the hospital. मसला pathway का नहीं था, लेकिन मसला शायद ये था कि in some instances उसका इस्तेमाल सही नहीं हुआ. But because of that, I mean the current situations, there was a review by the Department of Health, and now they've come with the decision that they're going to gradually वो Liverpool Care Pathway phase out करने जा रहे हैं अगले 6 महीने 1 साल के अंदर. और उनका मकसद ये है कि they will come up with a new end of life plan.
Thank you for touching on that. Unfortunately, we've come to the end of our program today. Thank you very much, Dr. Ahmed, for informing us about the LCP and palliative care. This was a very important and sensitive subject. It's vital that our Asian community is well informed about this topic, and thank you very much for phoning in as well. We just want to do a final message at all. Do you have a final message for our viewers?
No, I think especially for our Asian community, I think there's probably not much awareness about palliative care, and I think it's just to let the Asian community know that the help is out there for your near and dear ones in the community and in the hospice and the hospital, and yes.
Okay, so there's plenty of supportive care out there. I hope we've informed you well about the services available. Thank you very much for watching the programme with us, and we'll see you at the next programme. Thank you very much, Allah Hafiz.